And of course, we've done some with Paul as well, which is always entertaining, you know. I'd like to welcome you to the IMWG Conference Series coming to you today from Amsterdam. This conference series is coming after ASCO, just after the IMWG Summit and right before the EHA meeting, which is why we are here in Amsterdam. And so joining me today are two myeloma experts who are present for our workshop and also for EHA. I'm very pleased to welcome Dr. Joseph Mikhael, who is now based in part at the City of Hope and as well as at TGen in Phoenix. And I have the pleasure to have him as the Chief Medical Officer at the International Myeloma Foundation. So welcome.
Thank you.
And I'm especially pleased to have with me Philippe Moreau from the University of Nantes, who has obviously been very, very prominent in myeloma research and clinical trials in recent years. So what we're going to do today is review recently presented or published data. And so we are going to focus primarily on presentations from the recent ASCO meeting in Chicago, as well as upcoming abstracts at the EHA meeting here in Amsterdam. At the ASCO meeting, a huge number of abstracts presented, 5,600. Of those this year, 210 related to myeloma, 8 oral presentations, and quite a number of poster sessions. At the EHA meeting, 199 myeloma-related abstracts. There are 13 oral presentations. There is one special oral presentation, which is by Philippe Moreau, who will be presenting his frontline trial data with the Casiopeia trial that we'll be discussing in just a moment. 182 posters this year at EHA. The topics that we will cover are 5 topics. We will move from early disease, smoldering myeloma, through frontline therapy options, the use of maintenance, relapse therapies, and of course, the most exciting, the new agents currently coming through pipeline trials. So let's start with smoldering myeloma. There were 2 important presentations at ASCO and also coming up here at EHA. And the first of those was presented at the ASCO meeting by Maribí Mateos from Salamanca in Spain. And she was discussing smoldering myeloma as we transition from MGUS to smoldering myeloma to multiple myeloma. What are the practical factors that can be used to indicate a likelihood of progression? And the criteria for this particular analysis that she presented was, what are the factors predicting progression at 2 years? And so she presented the results of a data gathering project where patients with smoldering myeloma, a total population of around 2,500 patients gathered from around the world, were analyzed in terms of which factors predict progression at 2 years. And so from these data sets, a scoring system, a scoring tool has been developed, which incorporates the top 4 factors which indicate likelihood of progression at 2 years. And those 4 factors are the free light ratio, the level of the M component in the serum, the bone marrow plasma cell percentage in the bone marrow, and whether or not high-risk FISH abnormalities are present. And as you can see on this slide here on the right, it's possible to separate patients with a low score into those with a very, very low risk of progression at 2 years, and those with a score greater than 9 who have a much higher risk. And if we look at this in graphic Kaplan-Meier fashion, you can see in the high-risk case, 72.6% at 2 years, 80% at 3 years are patients with a score of 9 or greater using this system. And the dominant factor that influences this is actually the tumor burden, which is reflected by the percentage of plasma cells in the bone marrow. But obviously the free light ratio and the height of M component is important. And the presence of abnormal FISH does add a little bit. But it was also important to identify a very low-risk group of patients who should certainly be excluded from therapeutic interventions. As you can see over on the right, a 3.7% chance of progression at 2 years. The second study was a study in which risk classification was used, using actually some somewhat broader criteria. And this is a study presented by Sagar Loniol on behalf of the ECOG group, and it evaluated the treatment of patients with intermediate and high-risk myeloma with lenalidomide or with observation alone. And a lot of interest in this particular abstract. And the bottom line results of this study is that although there was overall impact in terms of progression-free survival with the administration of lenalidomide, in this case lenalidomide without dexamethasone, what is shown on this slide is that the impact was really confined to the patients with truly high risk, and there was not a significant benefit in patients with intermediate or low risk disease. In contrast to this, the updated results from the CSER trial are about to be presented here at EHA. In this case, patients with high-risk smoldering are treated with an aggressive approach, carfilzomib, lenalidomide dexamethasone, plus autologous stem cell transplant. Mary V. Mateos will present the results at a little short of 3 years, and these patients have done unusually well with this aggressive curative intent. Overall survival 98%, PFS 94% at the 30-month benchmark. And so from those data, there are two important topics. One, where do we stand with risk classification? And number two, where do we stand with treatment? We have some benefit with lenalidomide alone. We also have striking benefit with a very aggressive approach. And so I'd like to ask you both about your comments on both aspects. Perhaps, Joe, you'd like to comment first.
Yeah. No, I mean, I think the risk classification concept is so important to us, right? A few years ago, we redefined myeloma. We used to only define myeloma by having the CRAB criteria. You know, an analogy I always give is that if I go running today with my friend Philippe here, I don't have to wait till he's falling off a cliff to know we're in trouble if we're running near a cliff.
Right.
We used to define myeloma as literally falling off the cliff. Well, now we said, well, if you're getting really close, then we're going to be careful and we're going to pull you away from the cliff. And so we added those 3 criteria. And I think what this classification is doing is it helping us understand those people that are a little bit further away from the cliff in the smoldering group, which ones of those are actually still at high risk of getting into trouble with myeloma. So I think this kind of big database, 2,500 people, will hopefully lead not just to a risk classification of smoldering, it may with time help us further define the line of myeloma. There may come a day, I'm not going to be a prophet, but I think the day is going to come where we're going to have myeloma and basically MGUS and almost remove the element of smoldering myeloma so that we know that trigger point to start treating.
Right. I think the controversy right now is what to call that intermediate group. Is it still smoldering or is it early myeloma? I don't know. What do you think about that, Philippe?
I think that's very interesting because the criteria that were selected into this classification are very simple, in fact.
Yes.
Free light chain, the percentage of plasma cells within the bone marrow, the increase of the M component, and the FISH analysis. That's what we are doing in routine. So this is, it is possible to use this classification for all patients.
Yes.
And then I think that we should not treat patients too early, but it's very good to be able to select a patient population that will progress quite obviously very, very soon. And then we need to develop clinical trials with an early intervention to find the optimal treatment for those patients. And then we have two possibilities, either using a very aggressive strategy, such as the treatment proposed by the Spanish group. There is also a study ongoing in the US, very similar.
Trial, very similar, yes.
With all new agents available and stem cell transplantation, with the aim of curing patients.
Exactly.
But we need a very long follow-up to be sure that we may cure some patients. Or the other possibility is to use IMiD-based regimens such as lenalidomide in order to delay the time to progression. I'm not sure that we are going to cure patients with len alone. And this is a big issue because on the long term, what are we going to do with lenalidomide? Are we going to propose len for 5 years, 10 years? It may be not reasonable.
Practical,
practical and reasonable. So
and cost
these
effective.
are the options. Yes, obviously.
And I think also that the concept there, we sort of get into a gray area between, are you preventing a disease from happening, or are you delaying it? And I know that may sound like similar things, but they're very different. I don't think anyone really believes that lenalidomide by itself can do this. You know, in your lab that you had many years ago, you studied a lot of this, didn't you?
Yes.
Can you affect the immune environment around myeloma cells to prevent them from becoming more active?
Yes,
And it's a tricky area, isn't it?
It is a tricky area, and my feeling is that it is maybe unwise to be relying exclusively on some modulation as a prevention strategy. I think that ultimately the disease is progressing because of intrinsic genomic changes, and that's what we need to pay attention to.
I mean, it's hard to ignore the fact that now we have two big trials that have shown a benefit of giving lenalidomide with or without dexamethasone early on. So I don't think we're dismissing that. I just think in my clinic tomorrow and seeing patients, I'm not jumping to treat everybody with high-risk smoldering myeloma. No. I think, as we said before, we're probably going to redefine the disease a little bit more, but I think it's worth having a conversation with those patients now with a better risk stratification. And if I think my patient has a 70 or 80% chance of developing myeloma in the next 2 years, I'm not going to wait for them to fall off the cliff. Let's do something before. But for all those patients before then, I think it's important to continue to watch.
Absolutely. And so coming up, we do have a follow-on trial, which is lenalidomide dex versus Dara lendex. And so this will be very important. And then, as you said, we have the ASCENT trial, which is the aggressive approach similar to the CSER study. So we will have new information about both of those. But I think, for me at least, in clinical practice, we should be quite cautious about how we manage those patients.
Agreed.
Okay, so let's move on. There is a lot of new information about frontline therapy. As we've mentioned already, one of the key trials that has been presented is the Casiopeia trial. We also have the Maya trial. We also have the wonderful information that sub-Q Dara is available versus IV. We also have a very interesting study that looks at the merits of autologous transplant in the frontline setting. And then we have some early data about what really is the impact of having the 1114 translocation. So I'm just going to go briefly through these recent presentations and publications. I say both because in the case of the Casiopeia trial, which was presented at ASCO, during the presentation, the publication was also released online in the Lancet, and so this is one of the first times that we had both happening at once.
And Philippe made mention of it.
Yes.
He's looking at his watch saying, I think it's coming online right now.
I'm presenting it now, and it's hitting publication right now. And so obviously he's so familiar with the results. But clearly, as you might expect, there is a decisive benefit to adding daratumumab to the Velcade, thalidomide, and dexamethasone combination. And it's obvious in the amount of MRD negativity. It's also evident in terms of the progression-free survival. But it's interesting also that for patients who did achieve a deep response, that was important, whichever arm of the study that they were on. And so I'll look forward to your further comments on that, Philippe. The Maya study, daratumumab plus lenalidomide and dex, this actually was published in the New England Journal. We've had a rapid movement of data from presentation to publications, this one in the New England Journal. and as you might expect in this case, a clear benefit of the triplet versus the doublet. So we have those options in the frontline setting. These are the data that just show that daratumumab given subcutaneously is equivalent to IV. Interestingly, even slightly better, you know, and it may be that the sub-Q has a slightly longer exposure, and you can see the pharmacokinetics there, but obviously very safe in the sub-Q administration. Then the interesting thing presented from the Italian team was the results of the Forte trial. And the interesting thing which I made note of was that the KRD combination, if administered for 12 cycles, gave equivalent outcomes. For example, I've highlighted there the MRD level versus KRD plus autologous stem cell transplant. And so this was particularly helpful in the high-risk setting. So I'll be interested in hearing what you think about this in terms of the role of transplant in the frontline setting. And then just a little bit of data to say that we are understanding that patients with 1114, they do seem to do better with an IMiD proteasome inhibitor combo and also with autologous stem cell transplant. But now we will wait to see how will the use of venetoclax, the BCL2 inhibitor, influence our selection for treatment. And so perhaps I can come to you, Philippe, first on this one. So first of all, what is your bottom line for the Casiopeia study? And then how do you see this impacting our choice of therapy in the frontline setting?
Well, up to now, not only in the US, but also in Europe, before stem cell transplantation, we were using a triplet combination with a PI and an IMiD. VTD is standard of care in Europe, but in the US, VRD is standard of care. So we wanted to look at the impact of the addition of a monoclonal antibody, daratumumab, and the primary endpoint was the stringent CR rate after consolidation. So patients were randomized to receive VTD, auto VTD, plus or minus DARA, and then the first part of the analysis, the first part of the study, stringent CR as a primary endpoint, but also a number of secondary endpoints such as MRD negativity, PFS, and OS. And on a very large number of patients, more than 1,000 patients were randomized into the study. A huge study. We are seeing that the response is highly increased with the addition of daratumumab, but also this translates into a better progression-free survival. And we already have, despite a short follow-up of 18 months, we already have a trend for a better overall survival. So this, for the first time, may indicate that we need to use DARA or a CD38 antibody in the setting of stem cell transplantation. So we will have additional data soon coming from Europe because we have exactly the same study design with VRD plus or minus daratumumab, the Perseus study.
Right.
And I guess that in the near future, we will propose a quadruplet in the setting of stem cell transplantation, including a monoclonal antibody.
Yes, it does look like this is moving towards becoming a standard of care. And obviously we have other data with the DARA VMP and the non-transplant setting.
That's it, in fact. We had in the non-transplant setting the VMP plus or minus DARA, the Alcyone study. We are going to discuss about Maya, Lendex plus or minus DARA. So DARA is useful in the relapse setting, but I think that importantly, it can be also very useful as part of frontline treatment.
Yeah, so what's your take on this, Joe? I mean, we have the quadruplet, we have the triplet. How do you see this moving forward? How are we going to be selecting our treatment here?
Yeah, I mean, it's challenging in one respect. I mean, congratulations on a great study, by the way. I mean, I think this is so important to the myeloma community.
A huge study completed rapidly, as you mentioned.
Absolutely. You know, I think there may come a time where we're going to be giving quadruplets to everyone, but I think the timing is interesting with Maya, as you've shown, Brian. The way I look at it is, you know, we have three major classes of drugs: the proteasome inhibitors, the immunomodulatory drugs, and the monoclonal antibodies. And historically, we took one of each of those first two
Right.
added steroids, and treated patients who were going to transplant. Then eventually we started doing the same for transplant ineligible.
Right.
I think what Maya is teaching us now is out of these three, you can basically take your pick out of two of them. So you look at our patient factors, what's convenient to them? Do they want a more oral regimen? Do they have certain features that may sway you to one or another? I think we're getting a little bit of a signal that if you have high-risk myeloma, maybe you should probably still choose a proteasome inhibitor as at least one of the combination. And so if Maya gets approved in the U.S., which we suspect it will be in the near future,
absolutely.
docs can basically, with their patients, choose 2 out of those 3 until we actually start going with all 3 plus a steroid, that quadruplet.
Right.
So I think this was sentinel work, and I think, as you've mentioned, once we have the DARA VRD, I think most of us feel that's probably what we're going to do in the majority of patients before transplant. And those who aren't going to transplant, where they may have more comorbidities, we may go to the choose 2 out of the 3 kind of model.
Right.
What is interesting in the Maya study is that we had more than 40%, almost 40% of the patients that were older than 75 years.
Right.
And the feasibility of Lendex-Dara is very good. And we had a presentation at ASCO about the subgroup of patients older than 75 years. And the PFS is identical to that of the younger patient population. It means that we can propose this combination very easily to very old patients with myeloma. And now that we will have also Dara sub-Q available, it will be quite convenient to have the Lendex plus Dara combination. And if we are looking at the PFS analysis, we can anticipate that the median PFS in the Dara arm of the study will be better than 50 months.
Yes, it's going to be.
Those results
very,
are
very good.
achieved currently with stem cell transplantation in young patients. So
Absolutely.
I mean, this is really a game changer.
Yeah, striking
I agree.
that balance.
This is really a major step forward. And as you know, having improvement in the older population has been difficult. And so this is a true step forward. A treatment that is tolerable and providing this degree of benefit.
And it's the first study, the Maya study is really the first study ever to take 2 out of those 3 and give them indefinitely.
Yes.
Even in the SWOG study that you led, that with bortezomib and lenalidomide, the bortezomib had a defined period of time.
Absolutely, because
here
it's not
in Maya,
possible to
that's
give.
right. It's not possible to give long term. Here, I think that's one of the reasons why we're seeing such a great outcome. Not only do people tolerate it well, they're on it for longer. And we hope if we start incorporating sub-Q DARA, a 5-minute subcutaneous infusion is a lot easier than the hours that our patients are now spending in the therapy units.
So just before we move on, just to touch on, what was your take on the Forte trial? Do you think this will impact our thinking about the duration of the therapy and the role of transplant? We've been thinking about that with VRD and transplant. Whether if you just give it for a little bit longer, perhaps you don't need to do the transplant. Did this influence your thinking in that way?
I think that, the data are very important because our colleagues from Italy were able to look at MRD assessment at different time points, after induction, after consolidation, and for those patients receiving KRD alone, sequentially after 4 cycles and 12 cycles. And what we are seeing is that the MRD negativity rate is almost identical. That's a little higher with stem cell transplantation. But we don't have any PFS data. So I think that's really premature to say that we can maybe delay stem cell transplantation systematically. We need to have at least the PFS analysis.
So too soon.
Well, that's too soon, to my opinion. What is interesting is that they were also able to look during maintenance at the sustained MRD analysis, and they are showing that, in fact, some patients that did receive stem cell transplantation seem to benefit more with a longer duration of MRD negativity. So this also may impact our way of designing trials or proposing a duration of treatment based on this sequential analysis of MRD.
Okay, very good.
Yeah, I just, if I can quickly comment, I think that is such an important point because we thought maybe 12 months of KRD we can abandon transplant. And with the response rate so close, we wondered that. But it's a lesson in being patient and waiting for the results, because if it means that patients get a deep response, that's great. But if it doesn't last,
That's right.
the duration of that response is important. And the early data is a little concerning that more of those patients who didn't get transplant are relapsing. So we can't quite dispense with it yet, but I think we have to wait for time.
And it actually feeds into this next point, which is that there's not a lot of new data about maintenance. It's tough to get maintenance data because you have the long-term follow-up. But this is an interesting study from the German team showing that if you have a benefit with ongoing ixazomib, it's associated with a deepening of the response. And so a correlation between a deepening of the best response beyond a PR or a VGPR achieving MRD, and then that is associated with a longer PFS. And so I think that a little bit of data that we can use to indicate value for ixazomib in the maintenance setting. So I don't know how you guys view that.
Well, I mean, we're not using a lot of ixazomib maintenance in the U.S., mostly because lenalidomide is such a standard. But let's also remember that, lenalidomide can't always be given. Even in the ECOG study you mentioned up front, remember 51% of those patients came off. In the meta-analysis of the lenalidomide maintenance studies, around 30% of patients had to come off. So we already have almost a third of our patients who can't stay on lenalidomide. Now we could talk about how long they're supposed to be on, but that's a whole other discussion. So I think there is a role for ixazomib. I think even in the discussion in the working group over the last 2 days, I think there was a feeling that ixazomib's role is almost definitely in addition to something else in the maintenance setting.
Exactly.
And so if I have patients that have high-risk disease or that I want to add something to their lenalidomide, I'll reach for ixazomib because, as you said a few minutes ago, Brian, you're more likely to be able to give ixazomib longer term than bortezomib because of the neuropathy and other concerns. So I don't think it's the lead role, but it's a supporting role, if I can put it that way. And I think that is important for our patients because we want people to stay in remission for as long as possible. That time to first relapse is so important, and if we can push that out further, that could benefit them.
Yeah, and I think that ability to administer the drug is important. And I think that for that reason, there's some European trials where not just in maintenance, but even in the frontline setting for frail patients, it's part of the protocol.
That's it, in fact. In Europe, we cannot use ixazomib maintenance because it is not yet approved.
Right.
Well, we will see as soon as the drug will be approved if the physicians are using yes or no ixazomib. Currently, as you mentioned, len is standard of care as part of maintenance, and I agree with you, in fact. It could be very interesting to have len combined with ixazomib. We know that the combination of a PI and an IMID, there is a synergistic activity, and we can anticipate that we will delay progression. And there is a very interesting study ongoing in Spain. After stem cell transplantation, patients are randomized to receive len maintenance or len plus ixa. And this is the good study. That's not ixa versus placebo. That's len versus len plus ixa.
Yeah, very good. Okay.
And I think maybe the goal someday would be to find a way to stop.
Yeah.
Which are the right patients that we can
Some
stop.
stopping rules, maybe based on MRD assessment.
Maybe. Although it's difficult. We know that when you stop, you're not sure how long will the remission last. It's a difficult decision.
That's a difficult decision. We have to keep in mind the example of CML, for example. It took more than 10 years for us to understand that we could stop Glivec in patients with CML only after 5 years of molecular CR.
Right.
And then half of the patients never relapse. They were cured. And half of the patients may relapse.
Yes.
But we need at least to have this 5 years period of time with a molecular CR. Why not in myeloma, in fact?
Actually, yes, you're right. So I think it's going to take some time, and with the best precise MRD testing that we can come up with, probably.
Yeah.
Okay, so we're going to move forward into relapse therapies, and both of you have been very much involved in the assessment of regimens in the relapse setting. Recently, several have been presented. I'm just going to give those as examples of recent data. I think we were all interested to see the impact of the ixazomib is a ToxaMap, which is the anti-CD38 molecule similar to DARA. And as one might expect, a significant impact of the 3-drug combination versus the 2-drug in the PFS, overall survival, and a little bit for the MRD. I would have hoped to see maybe a little bit more improvement there. Then follow-up data on the daratumumab, carfilzomib, dexamethasone. Again, interesting thing here. High level of benefit across the board, including LEN refractory and LEN exposed. Then I think something that is quite important, as we have presented before and you guys know really well, we were very pleased to see the results of the ARROW trial presented last year indicating the benefit with once-a-week carfilzomib. There was a concern if this would be fully well tolerated in frail patients and elderly patients, and so we have new data indicating that the once a week is in fact tolerable for the older patients, frail patients, and we have data from several sources, this one plus actually a couple of studies from the IFM indicating that. And then a final study where I think there's a lot of interest is, and I would say rather unexpected, that there is significant value in adding elotuzumab to PomDex, and this is the study indicating the degree of benefit with the 3-drug combination at 1 year and 2 years in the PFS, 79 versus 68, 68 versus 49. So really a significant ongoing benefit with this triplet, which is obviously well tolerated, which is quite important. And so I know maybe I need to start with you first on this, Philippe. You've been particularly interested in how do we sort out these combinations, decide which one to give first or sequence them?
That's very important, in fact. As soon as we are starting to treat one specific patient, we have to anticipate and to know what will be available at the time of the relapse. And we discussed a lot during the last 2 days during the meeting about the number of patients that are receiving lenalidomide frontline.
Yes.
Not only young patients, but also elderly patients. And they are receiving len until progression. So many patients will progress on lenalidomide.
Yeah, so a major group.
Yeah, and then what to propose, what is the best option at the time of progression on lenalidomide. And we have now different possibilities. We have the combination of pomalidomide, bortezomib and dex, the PVD combination, based on the optimism study, with very good results, in fact.
Yes.
And the PFS that is more than something like 18 months. But we do also have data from phase 2 with Carfildex DARA, KD DARA.
Yep.
And KD DARA could be a good option in this situation. PomDex DARA or PomDex plus CD38 is probably a good option as well. So we have to think about how to sequence the treatment to find the best combination, in fact, of regimens to have a very long response and a very long survival.
Yes, yes. And as was discussed, what would be the cumulative cost as you sequence through all of those in terms of the PFS, the cumulative PFS benefit and the cumulative cost over those various regimens? And so, Joe, you've been involved, I know, particularly with the isatuximab. How do you see that fitting in? I know that is, if I understand correctly, a registration pathway, that ISA PomDex. So
yeah, this will almost definitely be isatuximab's indication, at least initially in the U.S.
Right.
Will be in combination with PomDex in people with more heavily relapsed myeloma. So sort of meeting the pomalidomide classic two prior lines.
Yes.
Whereas the pomalidomide bortezomib dex study you mentioned was a little bit earlier. That's why it's hard to compare the apples with the oranges in terms of the PFS. So you know, isatuximab is really a very similar molecule to daratumumab. It's given IV. It's a bit of a shorter infusion, although that'll be a bit of a moot point when dara becomes subcutaneous. But I think that's where
will ISA become sub-Q, by the way?
Not immediately. Not immediately.
Okay. But there is a development.
There is a
isatuximab sub-Q. Yeah.
but it won't be as obviously as quickly as daratumumab. And with the, as we discussed earlier in this program, with daratumumab coming earlier, when we think of sequencing, you classically think, well, at first relapse, I want to make sure I include daratumumab, but people may already be on it. So I think where ESAs get a fit is a little challenging because, to be honest, almost everybody will have had daratumumab, if not in their front line, then at their in front line at first relapse. We don't really know how effective isatuximab is once you fail daratumumab. I mean, I led a study in that realm.
There was a study.
I know. I started that study.
Yes. So can you give us some?
Yes, we need some results from that. Yes.
Early results.
When Dr. Richardson was asked about this at his presentation, he said, there was a study that has not yet been published. He didn't give the details. And obviously we're still working through the data, but the short version is that it really doesn't seem to overcome the resistance that people have with DARA. I mean, that may be one of the most important questions we have in myeloma right now, which is, what do you do with the patient that is failing daratumumab? Do you ever use DARA again or not? I think what we may come to, in my simple suggestion in the short term, is you probably don't want to give them a DARA or DARA-like drug immediately. You probably have to give the disease some time to almost reaccumulate the CD38s and potentially use it later. So maybe we'll get into this alternating-like situation.
There is another question mark, is that when we are using DARA during a long period of time, we are using DARA monthly. Yes. Then is it possible, if we are changing the schedule from monthly when the patient is progressing with a biochemical relapse, to move from the monthly to the weekly to try to salvage the rescue the patient, and that we don't have any data.
Right. I mean,
Dr. Richardson said that he has some examples in his clinics, but the data are not
examples. Well,
yes,
no, I've seen this also. Yes,
it's like the lenalidomide.
But we need proper data.
I think it's like lenalidomide maintenance. When people say, "Well, I'm on low dose lenalidomide maintenance, can I
increase the
rescue
dose,
it by increasing
add
the dose?"
dexamethasone.
I'm not sure it's going to be the definitive answer.
No,
so I think,
no.
in answer to your question, Brian, I think isatuximab will have a role. It'll be initially with pomalidomide, although it's going to be a partner with just about everybody else.
Sure.
But I think the majority of the time it's going to be well after daratumumab has been given.
And so one decision coming out of our working group summit here is that we do need to try to bring this information together and go forward with a publication to try to sort this out.
Yes.
And as was also discussed, sorting it out will be where a lot of the regimens are available, but also for many parts of the world where a lot of the drugs are not available. And so that's going to be important to sort that out for patients globally.
But some of the other studies that you mentioned, I think, are so important because we have these pool of drugs, and every time we add one drug, we're not adding one more option.
Right.
We're actually adding one more drug that can be combined with almost anything else.
5 new options.
That's right. That's why I think that the daratumumab Carfilzom combination is so important. Better data on the daratumumab and pomalidomide combination will be important for us. Because then you can look back and say, has my patient had this, that, or the other? What's the right menu? Well, and I hate to call it a cocktail, but what's the right mix of things that is going to work well for this patient based on what they had before? So that's why I think some of these studies, although they may not seem like they're adding a ton, they're actually adding more options that can make the discussion with the patient a lot more facilitated.
Absolutely. Okay, so a lot of excitement about the next topic, which was the new immune therapies in particular. And so obviously the highest visibility for the CAR T programs, and also the new BiTEs, the bispecific T-cell engagers, as well as a new IMID, basically a cell mod coming after the thalidomide, Revlimid, and pomalidomide. So just a little bit of data that has been presented recently. We have updates on the BB2121, which is the Celgene Bluebird CAR T product. Basically, just a little bit more follow-up indicating the value, the length of the remission, and the achievement of MRD. The number that people focus on is that the median duration of PFS is 11.8 months, and so people are balancing that length of response with what it takes to achieve this sort of treatment and the cost of this treatment. And then the big thing that's happening right now, and this is just another example that was presented, another type of CAR T cell. So we're seeing next generation CAR T cell therapies, many of them with different types of advantages, improved efficacy and safety. We are seeing fully humanized CAR Ts. We're seeing different target combinations. And so certainly it's not the end of which will be the best CAR T protocol, that's for sure. And then, of course, a lot of excitement about, well, perhaps the bispecific engagers would really be a good alternative to the CAR T. And so tremendous interest in this particular product, the Amgen 420. And just a little bit of follow-up. The first presentation on this was a dose finding, and definitely concern at the higher dose level of the 800 micrograms, where some unexpected, rather strange neuropathy occurred, which fortunately does seem to be reversible, but it led to a little bit of an expansion at the 400 microgram dose, but really limited data so far, 10 patients actually, with a 70% response rate, although they did indicate a 40% MRD level. So it's going to be interesting. I'll be interested in your thoughts about how this will move forward. And then, interesting just to see with this early data with the new cell mod, CC220. This was presented by Sagar Lonial in patients who have been previously exposed to Revlimid, pomalidomide, overall response rate of 31%. And so I think credible evidence of benefit here. We need to see how that might move forward. And then, of course, we are seeing a lot of information about selinexor, the STORM, the original selinexor dexamethasone, and then in combination with DARA, quite interesting. And there is expectation that selinexor will, in fact, hopefully receive FDA approval. We'll see how the FDA views the final follow-up on that. And so what's your perspective on those new therapies? We really do have so many options in terms of the CAR Ts, the BiTEs, and then we have these promising other agents. And so, Joe, what do you think? Let's take the CAR T cells and the BiTEs. What's your perspective on what's happening there?
Yeah, I mean, from the scientific
Yes.
geek in me goes crazy over this stuff. I mean,
Yes.
this is fantastic to think that we can, you know, take T cells out of a patient and train them to go back and fight the patient's tumor, or have a drug that puts one arm on the tumor and one arm on the T cell and gets them together. I mean,
Yes.
the science is overwhelming.
Yeah, tremendous.
But I think, you know, that's why I think the word CAR is appropriate for it, because it's kind of like early model cars, right?
Yeah,
we all
CAR
knew
T.
that they needed some help, right? So I feel like when we go to these presentations now, it's like we've got a car that's got more horsepower, or has a better sunroof, or has a better stereo system. Like, we're constantly making the cars better.
Yes.
But, you know, joking aside, like I think the challenge with CAR T cell therapy is going to be, one, that it's in a sense a boutique therapy. Mm-hmm. You know, if we have difficulty getting a simple autologous stem cell transplant to patients, and we hear all the time that even in the U.S., 40% of people who should get a transplant don't, it's going to be even harder for patients to access an expensive study that requires, you know, collection and machinery and you know, the creation of or all the work that we have to do with the T cells to multiply them and give them the receptor and give them back. So that's why I think I might be a little bit more excited around the bispecific concept, but it's also early on. I mean, right now, the AMG 420, this is a 28-day infusion.
Continuous infusion, yes.
So patients are getting
drugs. Although they do have the 701 coming along behind.
Correct. They have ones and that's what I mean, that further ones coming along. There was a really cute quote, a tweet from one of the prominent patient advocates at ASCO saying, well, if you're going to make me wear a backpack for 28 days, it better be a cute backpack. You know, but,
yes.
But I mean, there's still challenges, and I'm concerned about the neuropathy that you mentioned.
Yes.
Because when we saw the first presentation, it was one patient. When they updated it, it now happened in 2 patients. And any problem that we can't explain or adverse event we can't explain is a bit tricky. I don't think it'll be the end of bispecifics. If anything, I think it's just an early step forward. So I'm very excited about the concept of being able, if you will, take it off the shelf as opposed to going to CAR T. I think CAR T will play a role, there's no doubt, and we'll probably bring it earlier in the disease. I'm just not sure CAR T-cell therapy is for the masses, as it were. I think it's going to be really in a narrow group of patients.
So what's your take, Philippe?
Well, I fully agree. In fact, we have now 3 different classes of agents targeting BCMA, because the most important target is BCMA that is always expressed on the tumor cells. And then we have the CAR Ts, that's one shot.
Yes.
But we have this manufacturing process of more than 4 weeks, 5 weeks. And we know that patients may progress during this period of time. And this is a big issue, because not all patients are able to receive the CAR Ts. And then we have these drugs, either the BiTEs, and they need to be improved. As you mentioned, the continuous IV infusion is not feasible, in fact, in routine for the patients. And we also have these antibody drug conjugates, and one is in development from GSK.
Yes,
very interesting.
That's
a weekly infusion only. The drug is immediately available. It's off the shelf, so you can use it, in fact, immediately when you have a very advanced patient.
Yes.
But we do have some drawbacks and some ocular toxicity.
But that does seem to be manageable in that case.
It is manageable, but well, nevertheless, that's not well. We still have
not
to
ideal.
learn. So we have these drugs in development. Who will win? Single shot CAR Ts or other drugs? That's well, that's really challenging, but that's fascinating for sure.
Yeah. Okay. So you just touched on it. So these are being offered obviously in the relapse setting right now. What's your prediction in terms of some of these moving forward into earlier disease or even frontline? One comment I'll just make to introduce this is that the immunologists in our group are making it clear to us that the expression of BCMA is not 100% and is varying from cell to cell, and so we need to be cautious about hoping that it will be a truly decisive therapy. Even if we move it up early, maybe it won't be able to eliminate every cell. I don't know what you think about that.
I agree that maybe the best way of using CAR Ts will be earlier in the course of the disease. One shot in patients with a very low tumor burden, potentially almost MRD negative, or in CR but MRD positive, and mostly in high-risk patients. We have to try to treat patients with 17P, for example, or early relapse after stem cell transplantation. Those kind of patients very difficult to treat, in fact.
Yes.
So I'm really thinking that we should try to use them earlier.
Yes.
Yeah, I agree. I think partly the other challenge is that when we compare CAR T-cell therapy in myeloma to, let's say, CAR T-cell therapy in lymphoma and leukemia that have been so successful, almost curative in some of those conditions. Now, granted, some of those diseases are different. Obviously, we're in a sense comparing apples and oranges, but I think we've seen that although the CAR T-cell therapy may have a very deep response and last that 1 year, after that time, we do see quite a trail off. And so maybe younger T cells that are earlier on in the disease course.
You're talking about harvested sooner in the disease course.
Exactly. Harvest them sooner. Maybe they can be charged for longer, right? Maybe this is, I don't know, like a hybrid car or something.
Or even selecting the exact type of T cell to engineer.
Correct, because I think by the time we're giving these CAR T cell therapies to patients very late in the disease course, we're trying to engage their immune system, but their immune system is beaten down and weakened and may not have. But I absolutely agree with Philippe. I think he said it so nicely that I think we have to select in that highest risk patient, or right now we really struggle with what to do. And in that situation, it may be worth that extra time and effort and challenge of getting CAR T-cell therapy to them if that's going to be able to control their disease better.
Yeah, absolutely. Okay. So what I did here is I picked a number of the most prominent abstracts, and these are a few others, just examples of things that were presented. One you already touched on, Philippe, which is the GSK, the
916.
The 916.
The last abstract that you are
Yes,
mentioning.
yes. So,
Well, the data were published twice,
Yes.
in fact, and recently updated in Blood Cancer Journal. The median PFS in very advanced patients is almost is very close to that is observed with CAR-T. That's 1
exactly.
year.
It was right around a year,
PFS.
1 year, right? Which is
Now the company has completed a very large phase 2 study. We are going to have very soon phase 3 data as well, because this drug will be compared to Pomdex, will be compared to DARA-based combinations as well. So I'm quite confident on this GSK 916 compound.
so. What do you
Yeah, I
think?
agree too. I mean, going back to the concept of it again, almost like a CAR T cell light, like not having to go the the full way, a little bit different than the bispecific by not.
But off the shelf.
Yeah, off the shelf, it targets BCMA and then sort of drops a poison inside the cell after
Right.
it's grabbed onto the BCMA, for those who may not be familiar how it works.
Right.
So the concept makes a lot of sense. I agree, the results are really dramatic. It seems to be, in general, an easy drug to administer. There are these corneal challenges that we're trying to work through, what happens in the eye and what's the mechanism of it. We know that all monoclonal antibodies can actually get into the eye, but we're trying to understand this a little bit better. It gives people a bit of mostly just blurriness of vision that with time resolves, so that's good. The question is really if there's a way we can prevent it better. But I think that concept is critical, being able to give an off-the-shelf drug that has that kind of efficacy that's not a 28-day infusion. I mean, I think
Absolutely.
this is going to be very important for myeloma patients, for sure.
One other, perhaps just highlight the prognosis for patients with 1Q plus, and so obviously we focused on this a little bit more recently, and we've added it to our high-risk categories. However, there's a lot of things going with chromosome number 1, and I'm not sure what is the best way for us to assess all of those changes, the 1Q plus or the number of amplifications, all these different things. And so, so what do you think about the role of assessing the 1Q abnormalities or chromosome 1 abnormalities? You actually presented this in your high-risk discussion.
Yes, no, and I think there was actually quite a bit of consensus amongst our working group that this is an important thing.
Right.
I think we've always said, and we've said it so often during these presentations, Brian, myeloma is not one disease. It's such a spectrum. We have patients that have very slow-growing disease, almost indolent-like disease, as we call it, and those who have very high-risk, rapidly growing disease and everything in between. And sometimes there's been this discordance where we look at some of the numbers, you look at how a patient's doing. Well, is that a high-risk patient or not? And I think defining that high-risk category is really important. And our traditional markers of the key chromosomal changes that we've defined with p53 deletion and key translocations are there. But I think this 1Q is real. And I think the French led the way, actually, in helping us understand this better. And so I'm sure Philippe has more comments on it. But now, as with every updated database and registry, we're starting to see, actually, this is a real phenomenon.
Yes, so this was actually going back to the original total therapy experience to show that even in that setting, the 1Q was important.
Yeah. Well, we have recently defined a new score.
Yes.
The paper was published a few days ago in the GCO with a combination of several genomic abnormalities, including 1Q abnormalities. So definitely, it is a very important factor to be assessed at the time of diagnosis, and also sequentially at the time of the relapse as well. But in fact, very few of us, we are selecting a specific treatment option based on these abnormalities.
Yeah, so what do we do for 1Q plus, right?
That's it, in fact. So I think that, and we discussed this during the International Myeloma Working Group meeting in the last 2 days, we should have specific trials focusing on high-risk patients to try to identify the best options for them.
Right. But it is tricky because if we look at 1Q plus, which by the way we can, there is an interesting study just started at UCSF. The 1Q plus patients do overexpress CD46, and so they have a monoclonal antibody targeting that. And so I don't know if this is the way for the future. For each subgroup, we will have a specific strategy. We have obviously for 1114. 1Q plus, and maybe 17p. Maybe yes.
Yeah, it was striking to see that. I think when we did the survey of the working group, 73% of our international myeloma working group agreed that they approach the treatment of high-risk patients differently than standard risk. And it seemed that that approach was including a proteasome inhibitor, being a little bit more aggressive in the combination that you're using, and treating with the really making sure that their disease gets a deep response, and then continues until relapse.
Maintenance with the PI,
yeah,
and not maybe an IMID. In Europe, tandem stem cell transplantation in high-risk patients.
Right.
So yes, that's true. We are treating them differently.
Right. So what do you think about some newer data where these factors are important certainly early on and maybe later in the disease? However, later in the disease, it may be that completely new and additional mutations like KRAS and NRAS and other mutations could be driving the relapsing and progressing disease. How do you think about that?
Well, we are assessing systematically at the time of each relapse. But that's only for to collect the data and to try to see if a specific treatment was able to overcome this the occurrence of a new abnormality. But we are not treating according to a new finding.
But not yet. I mean, look at the whole cancer world is going this way, right? We have these so-called basket studies and different trials where we're doing studying the genomics as deeply as we can in a tumor. And, we've seen this in myeloma. We had a case in our clinic a few years back where we did this deep analysis and found that this patient had an unusual BRAF mutation, so something that we might usually see in a solid tumor, and we were able to get them a BRAF drug, right? So we had to call our solid tumor friends and understand it, because even though myeloma is a distinct disease, it seems that later and later in disease course, cancers sadly become a little bit more alike. And so if we can take that genetic information, really personalize it. Now this is challenging because I don't want all the patients listening in to say, oh, I need that test because I want to know what's going on. Because it's still a very small percentage of people. But I think as we gain this information, we find that, somewhere around 8% of patients have a BRAF mutation. Or, as you mentioned, the KRAS and NRAS, we don't have specific therapies for them yet. No, a lot of work is being done to try and develop them.
But for the audience, maybe we have to explain that not all the cells are harboring the mutation.
Correct.
And, one point is that BRAF, that's 5 to 8% of the patients that are mutated, so that's very few, in fact. But inside the group of patients with a mutation, some of them have this mutation only on 20% of the cells.
Correct.
So it means that 80% of the cells will not respond to a specific treatment targeting BRAF. So we have really to be careful when claiming that we can use targeted treatment. That's not that simple.
Yeah, so I actually fully agree with that. And there's some recent single-cell analyses that really reinforce that. If you look at that subpopulation with like 1Q plus or 17p, if you look at the subclones, they have multiple additional mutations that would be challenging to overcome, in fact. Okay, so are there any final things that you would like to emphasize? Both of you are involved with clinical trials. What do you see as the key next trial or trial that was going to inform us most, that you're of all the different trials that are coming out, that will be the most informative as we're trying to think of our next best therapies?
Well, we've got almost like an alphabet soup of trials. Which is great.
I'm saying this because we heard about so many trials at the end of our summit, but is there one or two trials that stand out where we really need the answer?
Well, in the frontline setting, for me right now, I think working on Philippe's great work with the Casiopeia study will be this Griffin study, where we do daratumumab, bortezomib, lenalidomide, dexamethasone. That quadruplet, we need to see that study and really prove that adding dara, it makes a difference to those patients. I think that could have the greatest impact in the short term, at least in frontline patients.
I agree.
Yes.
Definitely, that's we are enrolling patients in Europe, all over Europe.
Right.
In the EMN Perseus study with VRD plus or minus daratumumab, stem cell transplantation, and a fixed duration of maintenance, and we are comparing LEN versus LEN-DARA maintenance, 2 years. And I think that we can have a subgroup of patients that will never relapse. And
With this.
we have a serial assessment of MRD. And for those patients reaching MRD negativity very early after induction, for example, and before stem cell transplantation with a quadruplet combination, maybe those patients will receive the entire treatment and will remain MRD negative during a very, very long period of time, maybe potentially cured.
Yes, yes. So, well, that's good to end on a note like this, where we can envisage a combination that will give you MRD negative and maybe be sustained in that way. That's very encouraging. And so I would say a takeaway message for me is that all of these trial results give us so many options and so many things that could really have a powerful impact for our patients. And so I think that in closing, I'd definitely like to thank both of you guys for coming. I know just getting here was quite a challenge for Philippe, and sticking around to do these extra things we really, really appreciate. So thank our audience today, and especially thank our sponsors. And we hope you enjoy this, and you'll be ready for the next time that we report, which I think will be from ASH. So thank you for your attention.